Sometimes the difference between a healed foot and an amputated limb is not only the wound itself, but the words used to describe it. Welcome back to Diabetic Fit Files, the podcast where we decode the science, psychology, politics, unfortunately, and hidden language of diabetic wound care. So, one thing I do notice is there are magic words in wound care because it actually dictates the certain outcomes for patients to actually be taken seriously. And not all patients know these magic words, okay? Because patients don't know the magic words to let somebody know that they need to be taken seriously. Because in medicine, words are not words. Words actually trigger a sense of urgency, reimbursement, consultation, admission, surgery, vascular intervention, antibiotics, operating room time, insurance approval, and sometimes limb salvage. If anybody knows about insurance and wording, it's us because it makes a whole difference, right? The patient can say, my foot hurts, but nobody can move, right? But if somebody says the patient has a limb-threatening ischemia with suspected deep space infection and systemic inflammatory response, all of a sudden, the phones are ringing, specialists appear, beds open, vascular gets called, infectious disease arrives, surgery is scheduled, okay? So this episode is about the psychology of medical language, hierarchy of dangerous wound terms, words that can save limbs, words that get ignored, and how clinicians, patients can communicate wounds properly before a catastrophe occurs. Because like I said, you know what? I really don't care anymore if somebody hears this or not. There was an incident, they thought neck fascia was a flu. They thought the patient feeling weak, the patient getting worse was the flu, and the patient had necrotizing fasciitis. So let's talk about the dangerous reality of understanding wounds. One of the biggest problems of wound care globally is minimization. The patient can say it's just a blister, it's just a sore, it's a corn, it's a cracked skin. Families say it doesn't look bad. Even clinicians sometimes document small ulcer, minimal redness, localized drainage, just dry gangrene when it's not dry gangrene, it's wet gangrene actually. Meanwhile, the bone is getting infected. Gas is forming, perfusion is collapsing, tissue pressure is rising, bacteria is tunneling through the fascial planes. The diabetic foot ulcer is one of the most underestimated conditions in medicine, in my opinion. Research has shown diabetic foot ulcers precede the majority of non-traumatic amputations worldwide. Why is that? Because they underestimate the severity of a diabetic foot ulcer. They underestimate how bad it is right now, okay? The minimization of a diabetic foot ulcer. Yet, patients often get triage even less urgency than some people with chest pain. And chest pain is severely urgent, okay? No matter what. And they even have something, okay, we'll go into that in another episode. But why? Because the language that shapes it perceives danger. Everybody thinks when they think something on foot, they don't think of urgency. But yes, you can die. You can die from a foot ulcer, becoming septic or having neck fascia or anything, okay? So magic words that can trigger action. So the word limb threatening. This is a phrase that changes everything. It's not saying just a foot wound, not saying just a foot problem, not saying it's a foot infection. Using the term limb threatening diabetic foot infection. This is a magic phrase, okay? If anybody ignores this phrase, that's neglectful. That phrase tells the system that time matters. The tissue is dying, salvage windows are closing. This terminology aligns with major vascular and wound care guidelines. Once limb threatening enters the documentation, vascular surgeons pay attention. Hospitals escalate the urgency. Insurers recognize the severity. The multidisciplinary teams are mobilized. Next word. There is a massive difference between saying poor circulation and critical limb ischemia. The first one sounds vague. The second one sounds like a catastrophe. This is because critical limb ischemia means oxygen delivery is failing, already failed. Tissue death is occurring. Healing potential is collapsing. It is associated with high amputation risk, cardiovascular mortality, severe systemic vascular disease. When clinicians use accurate vascular terminology, angiograms happen faster, revascularization becomes urgent, perfusion is quantified. Now, one of the most powerful terms when it comes in our world of wound care is not, do not say the wound goes deep, okay? Feelings go deep. There is a concern for osteomyelitis. There's a concern for a deep space abscess. These words change antibiotic strategy. This changes imaging urgency. This changes surgical planning. This changes hospitalization. The hospitalization most likely. The amputation risk assessment will be more in depth. Osteomyelitis sounds serious because it is serious. It's an infection of the bone. Like I keep on telling you, think about how serious osteomyelitis is. We have bones from dinosaurs from millions of years ago or thousands, I don't know. But with osteomyelitis, there's no evidence because the bacteria eats the bone. So think about how serious osteomyelitis is. Bone infection transfers a simple ulcer into a potentially limb-threatening condition. Now, a few more phrases that can help create urgency. Necrotizing soft tissue infection. Like I said, I have gotten to the peak of being irked when I saw somebody misdiagnose necrotizing fasciitis. That was it for me. Okay? When you misdiagnose neck fasc, and I'm saying it is neck fasc, and you're letting days go by or time go by and saying, no, it's just dry gangrene, and it's necrotizing fasciitis, that's the end for me. That's the end for me. That's it. This phrase, necrotizing soft tissue infection, it's not gangrene. It's not wet gangrene, okay? It's not even, it's not dry gangrene, okay? Necrotizing soft tissue infection is a big deal. This phrase means that there is tissue destruction that is rapidly spreading. Bacteria is producing toxins. The fascia is dying. Mortality risk is rising by the hour. This does not mean there's redness, swelling, cellulitis. This does not mean that there's dry gangrene, okay? This is a surgical emergency. People have died from this by being misdiagnosed, being diagnosed too late. Source control is needed immediately. Words determine speed. Next, deep space abscess. A tiny plantar opening can hide massive undermining, tendon sheath infection, compartment spread, midfoot destruction. Phrase, deep space abscess, okay? Immediately, this tells the surgeon that this infection is not superficial. Pressure is building up internally. Drainage alone may fail. Exploration is most likely necessary, okay? The term changes the seriousness of the entire encounter. Now, systemic signs. Sometimes the words are not just local anymore. Magic words like tachycardia, hypotension. I asked when the patient had neck fat. I said, did y'all take the blood pressure? No. Did y'all check the blood? No. What are we doing here? What are we doing here? And you're going against me. And I'm saying it's neck fat, and you're saying it's dry gangrene. What are we doing here? What are we doing here? And you did nothing that was necessary to prove that I was wrong, that I ended up being right, unfortunately. And you thought it was a flu too. Ridiculous. So, magic words like tachycardia, sepsis, altered mental status. The patient even had an altered mental status. They couldn't think well. They couldn't drive anymore. They were weak. Oh no, it's dry gangrene. No, it's neck fast because they're getting septic. Once these systemic language enters the chart, patient move from outpatient to inpatient thinking. You think about the risk increase dramatically. You think about the mortality rate, okay? Next, this phrase terrifies a lot of clinicians, and for good reason. Soft tissue emphysema or gas in the tissue or gas forming infection. These words immediately trigger surgical consultation, emergent imaging, broad spectrum antibiotics, concern for anaerobic organisms, because gas in tissue means necrotizing infection, severe anaerobic infection, rapidly progressive destruction. So, why does the psychology of this medical terminology and language matter? Why do these words matter so much? Because the brain triages danger linguistically. Medicine functions on a pattern recognition. Thank God again for my residency. Y'all will hear me always say that because the pattern recognition is on point because they taught us so well. Certain phrases activate the alarm system, the protocols, the institution pathways, So think about it. Which sounds more dangerous? Footsore or neuroischemic plantar ulcer with exposed tendon and suspected osteomyelitis. Same foot, but different response, okay? And we have to get better with the terminology so we can understand each other better. Words patients should never ignore, okay? Patients need to know which phrases mean, like do not wait, okay? These words mean infection, ischemia, gangrene, bone infection, abscess, necrosis, sepsis, poor blood flow, critical, deep, exposed bone, malodorous, crepitus. If the clinician says any of those words, this is not casual. This means tissue survival is in jeopardy, okay? Not somebody saying, I'm worried about your blood flow. No, poor blood flow. This is an urgency thing. So, in many low resource settings, wounds get described very vaguely very often. Imaging is delayed very often. Vascular language is underused. Multidisciplinary terminology is usually absent. Patients just hear, clean it, and will watch it. Meanwhile, the perfusion is failing, the infection spreads and osteomyelitis develops silently. In many countries, limb salvage systems are very underdeveloped, and the absence of aggressive wound terminology delays this escalation. So, what's the opposite problem? Overusing dramatic terms. Not every wound is gangrene. Not every wound is sepsis. Not every wound is limb threatening, okay? But in my opinion, I think any diabetic ulcer can be limb threatening, and that's the truth, okay? But overstating disease can create panic. You have to create urgency, but yet hope. That's the thing. You have to create urgency and hope at the same time. And trust. Urgency, hope, and trust needs to be developed in that moment, okay? If you overstate diseases, you do increase unnecessary admissions, do lead to antibiotic overuse, and it erodes the trust. So the goal is not fear, the goal is precision. Correct terminology saves lives. So what could be one of the most useful phrases in wound care? Time-sensitive limb salvage. Use that phrase. That's the ultimate magic phrase in limb salvage. Time-sensitive limb salvage, okay? This phrase reframes the wound entirely. It's not just for dressing changes, not just for local care, not just for watching it, but this is a race against biology because diabetic wounds are dynamic, okay? They are a dynamic system. Perfusion changes, bacterial burden load changes, inflammatory cascades evolve hourly. Pressure reshapes tissue destruction continuously. Limb salvage is time-sensitive medicine. So, what can us as clinicians learn? We should learn how to document precisely, describe death accurately, identify ischemia early, communicate urgency very clearly, and make sure it gets done. Avoid minimizing dangerous wounds. That is a huge deal. I've seen it firsthand. The chart is not paperwork. The chart becomes a legal record, a triage signal, insurance justification, and a roadmap for the next clinician. Language can save limbs. And in final reflection, a diabetic foot ulcer often begins silently. Small opening, minimal pain, little drainage, but underneath, nerves are failing, the blood flow is collapsing, the bacteria is organizing, the pressure is destroying. And sometimes the first step towards saving a limb is finally calling the wound what it truly is, because the right words create urgency, the right words mobilizes the right teams, the right words accelerate the intervention, the right words changes the outcome. The magic words in wound care are not just magic because they sound impressive. They are magic because it forces the reality into the room. So in the end, we are here to decode the hidden language of limb salvage, diabetic wounds, infection, perfusion, and healing. And remember, a wound ignored by language may become a limb ignored by the system. And this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.